más.
Thank you very much, and thank you for inviting me. I feel very privileged to be able to visit your beautiful country. So I've been asked to give a lecture about the efficacy of diet and probiotics in IBS, both of which I think are controversial areas. So I'm going to go through the evidence for the efficacy of diet and probiotics. I'm going to try and focus on randomized controlled trials and meta-analyses. I'm going to show you some evidence from translational studies just to support some of the data I'm going to show you, and I'll summarize other advances where appropriate. So the first thing to say is that postprandial symptoms are very common in IBS. You can see this study from Magnus Simron's group showing symptoms like fullness, bloating, and discomfort starting to reach a peak within 30 to 60 minutes after ingestion of a meal. Why does that happen? Well, many patients with IBS report food intolerances and believe that food is the culprit for their symptoms or one of the culprits, but this is often not confirmed on double-blind testing. What are these potential culprits? Possibly fibre. Insoluble fibre has been reported to exacerbate symptoms in some patients, but there's also evidence soluble fibre may help, and I'll touch on that later. Obviously, FODMAPs, which are fermentable and have fermentative and osmotic effects. And then there's wheat. So gluten itself may have effects on barrier integrity in the intestine. As you know, I'm sure, fructan is itself a FODMAP. And also ATIs, amylase trypsin inhibitors, can have immunological effects. Why should fibre work in IBS? Well, one of the theories is that in IBS with constipation, transit is reduced, and fibre may accelerate transit time. Fibre is also fermented, and this may have effects via short-chain fatty acid production or even anti-inflammatory properties. And fibre may also be acting as a prebiotic, which could lead to beneficial alterations in the microbiota. This is a cross-sectional survey from Peter Warwell's group showing the effect of different types of fibre in patients with IBS. And you can see that almost 60% of people with IBS reported that bran made their symptoms worse, whereas around about 40% of people felt that isbagula had improved their symptoms. Now, obviously, this is uncontrolled data, but here is a large RCT from the Netherlands, which was published in the BMJ 15 years ago, showing the effects of both isbagula and bran versus a placebo. And you can see that over the 12 weeks of the study, isbagula was superior to placebo at multiple time points, as well as at the end of the study. And also bran was superior to placebo at the end of the study. Translating that into a summary of all the evidence, this is our meta-analysis, a pairwise meta-analysis of the trials themselves, looking at the effects of wheat bran in IBS. And you can see that in these 6 RCTs, the relative risk of remaining symptomatic is not significantly lower with bran than with placebo, but equally not worse. However, in these 7 trials of isbagula, you can see that the relative risk of remaining symptomatic is significantly lower with isbagula than with placebo, and this is a modest effect. It's a number needed to treat of around 7 or 8. This is Peter Gibson's seminal trial of a low FODMAP diet, which was a crossover trial in 30 patients with IBS versus a habitual diet. And you can see that over the 3 weeks of the study prior to crossover, the low FODMAP diet was superior to the habitual diet in terms of its effect on global symptoms. This is a meta-analysis that we performed of all the available trials of a low FODMAP diet to inform the British Society of Gastroenterology guidelines for IBS management. And I think it's important to look at the forest plot here carefully. The trials towards the top of the forest plot are all comparing a low FODMAP diet with British Dietetic Association standard dietary advice, and you can see that the effects there are not so great. And as you move down the forest plot to Staudacher and Helmos, which are sham dietary controlled trials, again, the effects are not so great. But when you move down from Harvey onto Macintosh, we're now looking at trials that are versus a habitual diet, in other words, no intervention, or even a high FODMAP containing diet. So the effects of the diet are variable, and there is heterogeneity in this meta-analysis. And so that gave us the idea to perform a network meta-analysis, because these interventions have not been compared with each other, they've only been compared with a low FODMAP diet. So for instance, a BDA or NICE dietary advice diet has never been compared with anything other than low FODMAP diet at the time we did this meta-analysis, and we didn't know whether it was superior to, for instance, habitual diet. You can see here that we have 13 trials of low FODMAP diet, the majority of the trials and the majority of the patients, but also 5 trials of BDA NICE dietary advice. And in a network meta-analysis, we can study the ranking of these interventions for the treatment of IBS. And you can see for global symptoms in IBS, the low FODMAP diet came out top, and it dominated all the other dietary interventions. So it was superior to the BDA NICE diet, and also sham and habitual diet, and also, perhaps not surprisingly, a high FODMAP containing diet. Similarly, for abdominal pain, low FODMAP diet was ranked first, but here it only outranked sham dietary advice. In terms of abdominal bloating, again, low FODMAP diet came out top, and here it outranked the BDA and NICE dietary advice. It was significantly superior to it. And then lastly, for the effect on bowel habit, again, the low FODMAP diet came out top, but here there was no difference between any of the diets themselves in terms of their efficacy. I'm now going to talk quickly about gluten. So this is again another Peter Gibson trial, which is a trial where patients who'd responded to a gluten-free diet were randomized to have their diet spiked with gluten or with a placebo for 6 weeks. And you can see that particularly within the first week of the study, gluten caused an exacerbation of symptoms of IBS, and that continued throughout the study. This is a nice trial from Imran Aziz's group in Sheffield, which was published subsequent to our network meta-analysis, looking at the efficacy of both low FODMAP diet and a gluten-free diet compared with the standard BDA dietary advice in around about 100 patients with IBS. And you can see that all 3 diets actually ranked or performed fairly similarly in terms of the proportion of people who responded to treatment. But I would suggest that this trial is probably underpowered. You can see there is actually a 15 or 16% difference between the 2 active interventions and the BDA NICE diet. Interestingly, what came out of this trial was that patients were asked about how easy it was to integrate the dietary advice they were given into their normal life. And you can see that both the gluten-free diet and the low FODMAP diet led to extra time to shop and were more expensive, whereas the BDA NICE dietary advice was felt to be more easy to incorporate into life in general. This is emerging data from Bill Che's group, looking at the effect of what's called a FODMAP simple diet, which excludes only fructans or galacto-oligosaccharides over 4 weeks versus a low FODMAP diet. Again, this is a small trial. It's only 35 patients. It's a pilot trial, really, so it should just be viewed as exploratory. But you can see that there were similar effects in terms of the effect on abdominal pain, bloating, discomfort, the stool consistency and the composite endpoint of pain and stool consistency favoured the low FODMAP diet. But the number of patients here is probably too small to be able to draw any firm conclusions. Again, emerging data from Heidi Staudacher, looking at the effect of a Mediterranean diet in patients with IBS, and also these patients had to have the presence of anxiety or depression at baseline. And you can see that, again, an exploratory study, but the response rate was significantly higher according to the IBS symptom severity scale after 6 weeks of the diet compared with staying on your habitual diet. And interestingly, the diet also seemed to improve anxiety and depression scores in these patients compared with the habitual diet. So I'm going to summarize for dietary interventions now. Soluble fiber, ispagula particularly, is superior to placebo for IBS. I don't think we know that that's a effect that's limited to IBS with constipation because most trials recruit unselected patients. There's no trial evidence to support the use of insoluble fibre or bran, but equally no RCT evidence to suggest it exacerbates symptoms. I've shown you that a low FODMAP diet is superior to all other diets for global symptoms, some benefits for pain and bloating, but not for bowel habit. I would caution that most trials have not studied the full 3 phases of the diet, so the reintroduction and personalisation phase are not studied in these trials. And I think there's also very much caution needed in patients who've already developed restrictive eating patterns around a diet that is itself very restrictive. Gluten-free diet performs similarly head-to-head to a low FODMAP diet, and it may be easier to incorporate into daily life. And I'd say that data are emerging for a FODMAP simple and a Mediterranean diet. More trials are warranted. I think those data are very interesting. So with that, I'm going to move on to probiotics and why should they work in IBS. As we know, some studies show alterations in the gut flora and dysbiosis in people with irritable bowel syndrome. We know that IBS can occur following gastroenteritis, so about 1 in 10 people with IBS will be able to identify that it came on after a food poisoning illness, and that is associated with dysmotility and perhaps chronic inflammation. I'm going to show you in a minute that the probiotics have the ability to induce pain sensing receptors and also attenuate visceral hypersensitivity and dysmotility in animal models. So this is a study from Nature Medicine showing that Lactobacillus acidophilus can induce the expression of nociceptive receptors in mice compared with a placebo after 15 days of treatment, both opioid and cannabinoid receptors. This is a study from Elena Verdu showing that in a mouse model of post-infectious IBS, administration of Lactobacillus paracasei can normalize the dysmotility that is seen in the infected control mouse compared with the uninfected mouse. You can see that with the L. paracasei, the tension comes down to that seen with the uninfected control. And this is another animal study showing that in rats under stress, so if you restrain their limbs and measure visceral hypersensitivity with balloon distension, you can see that that is high in the light green line, but that can come down with another lactobacillus with the actual formal limb restraint, which is comparable to the sham stress model. So what's the evidence for the efficacy of probiotics in humans rather than in mice? So we updated our meta-analysis last year. We identified 82 trials. We're now looking at 10,000 patients with IBS in these trials. We managed to get dichotomous data, so in other words, whether patients improved or did not improve. And we also extracted mean scores for global symptoms. And because there were so many trials, we thought we should start looking at whether there were benefits of particular probiotics according to individual symptoms, so abdominal pain and also abdominal bloating or distension. Because we had mean symptom scores, there is a way of imputing improvement or non-improvement from those data, which increases the number of patients and the number of trials in the analyses. I'm going to say right up front that there was heterogeneity in most of our analyses. Only 24 of the trials were at low risk of bias, and very few of these trials are conducted in patients with IBS with constipation. So this is the evidence for the efficacy of combination probiotics. Again, we're looking at the relative risk of remaining symptomatic, and you can see in this forest plot that that is reduced with combinations of probiotics, but these are all very different combinations, and you can see again there's heterogeneity between these trials. Some of the trials are negative, some of them are very strongly positive. This is a probiotic that some of you may have heard of. It may be something that you recommend to patients, so VSL number 3 or Vivamax, and you can see that in these trials, 4 trials, there was no benefit of VSL number 3 versus a placebo, so this is one of the better known combinations. This is lactobacillus containing probiotics for global symptoms, again a benefit. You can see that the effect is modest, the confidence interval nearly touches 1, it's 0.98, but what's interesting in this group of trials is that this particular lactobacillus, plantarum 299V, comes out as being effective for global symptoms. Bifidobacterium-containing probiotics, again for global symptoms, and these are all the trials of those, and you can see that there's a trend towards a benefit, but this is not statistically significant. You can see the confidence interval crosses 1. Bacillus-containing probiotics, again, these were effective, but these are 3 relatively small trials, not that many patients in them. If we move on to combination probiotics for abdominal pain, again, you can see that overall, when we class all of them together, there is a benefit, but again, there's lots of heterogeneity between these studies. And again, when we look at VSL number 3 or Vivamax, you can see there is no beneficial effect. And this is the combination that's studied in the most trials. Lactobacillus-containing probiotics were again beneficial for abdominal pain. As a group, this time the 299V preparation was not significantly better. And then Saccharomyces containing probiotics for abdominal pain, again as a group, these were beneficial, but that was limited to this Saccharomyces cerevisiae, which is a form of brewer's yeast. So that was beneficial for abdominal pain. And then again, Bifidobacterium containing probiotics overall in the 3 trials here were beneficial, but that effect is again modest. You can see that the confidence interval is approaching 1. And then Bacillus containing probiotics, again, the 3 small trials, again, quite an extreme result. You can see that these trials show a benefit. And then finally, the last symptom, abdominal bloating, which we all really struggle to treat. So obviously we were hoping that some clear messages were going to come out here. But again, heterogeneity in the combination probiotics, no benefit of VSL number 3, although perhaps a trend towards 1. Bacillus-containing probiotics, again, these 3 small trials, again, showing quite a big effect. I'm skeptical that is genuine. So in conclusion, efficacy of probiotics in IBS. Probiotics may have multiple beneficial effects in IBS, but I would say the results of individual trials are conflicting. Many trials are very poorly designed. They're of a relatively short duration, so they don't use FDA-recommended endpoints or FDA-recommended durations. And even when we have a meta-analysis of 82 trials with over 10,000 patients, it's hard to disentangle what the efficacious products are. Just to summarize again, combinations were beneficial for global symptoms, pain, and bloating or distension, but there's no clear evidence for any particular combination. Lactobacillus products were beneficial for global symptoms and pain, and Lactobacillus plantarum 299V for global symptoms alone. Saccharomyces products beneficial for pain, but that was limited to this brewer's yeast. And Bifidobacterium products, again, were beneficial for pain, but that was modest. And then finally, these 3 smaller trials of the Bacillus products showed quite extreme results for all the symptoms we studied. So with that, I'm going to finish. And thank you very much for asking me to speak this morning.
Thank you very much.